بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Hello, my dear brothers. Today we'll talk about the corneal ulcer, which is the second part of the cornea lectures, and this lecture is for undergraduate level. So I will cover today these items. Is it ulcer? Firstly, the definition of ulcer. Then, is it ulcer? Definition of the cause, approaches to diagnosis, investigations, and finally the treatments. We have talked that in the first part about the anatomy and physiology of the cornea, and I told you that the cornea is consisting of 6 layers, starting with the epithelium, then corneal stroma, and finally the decimate endothelium complex. So, ulcer is defined as discontinuation of the normal epithelial surface of the cornea associated with necrosis of the surrounding corneal tissues. So, I will tell you here about some important points. Uh, Firstly, discontinuation means tissue loss, which is different than the corneal scratch. So you have to differentiate between the corneal scratch and the corneal ulcer. Corneal scratch means that there is an injury to the corneal surface, removing part of the epithelium, just epithelial layer, just part of the epithelium, which is not associated with inflammation, which is not associated with uh, induration, which is not associated with infiltrations. And there is no loss of the pigments, there is no loss of stroma, so there is no ulcer. So you have to differentiate in your definition and in your mind between the corneal scratch, which may heal within 24 hours with no problems, uh, and the corneal ulcer. And both of them will be presented by pain, but you have to differentiate them on clinical examination. The second issue that the corneal ulcer is a process of the tissue necrosis and other tissue events, or I mean pathophysiological events happening at the level of the tissues, which is not related, which is not stopping at any layer. It may go deeply, even in the deep stroma, and it may go for full thickness necrosis and perforation of the cornea. So the corneal ulcer could be bacterial corneal ulcer, which is synonymly with one of its synonym is the hypopian ulcer. It may be named hypopian ulcer. Second type, fungal corneal ulcer, viral corneal ulcer, and finally protozoal corneal ulcer. And these are the types of infective corneal ulcer. So, the etiology of the corneal ulcer, it could be non-infectious or infectious. I told you just now about the infectious. But the non-infectious could be systemic, could be related to systemic autoimmune disease or inflammatory disease, or due to local toxic factor. Infective corneal ulcer, the risk factors for the infective corneal ulcer. Infective corneal ulcer means corneal ulcer due to an infective agent, a microbiological agent. So the risk factors which may increase the incidence of corneal ulcer, which is an infective ulcer, is a contact lens wearing, and the commonest type is acanthamoeba keratitis, followed by the fungal keratitis. But it's not a must to be acanthamoeba or fungal. It could be bacterial, but commonly it's acanthamoeba, which is protozoal or fungal in the contact lens wearers, because the acanthamoeba may grow up at the contact lens and the contact lens preservative fluids. The fungal, because of the wetting of the contact lens and the container, if it's not cleaned properly and thoroughly all the time, it may develop fungal colonies. So the contact lens wearers are prone to have a corneal ulceration. Second one is trauma, which may happen due to occupational exposure, like in the workers who are in exposure to flying objects, who are working in the field of like in carpenter, like in the workers who are exposed to the thermal keratopathy, like in the welding workers. All of them are um, at high incidence of having corneal ulceration. Also, trauma with the vegetable matter trauma, which may happen to the farmers, especially because they are living in the farms, and so they are prone to have a corneal scratch and corneal trauma with the vegetable matters and woody matters. So you have to think firstly in such patients with the fungal keratitis, and you have to confirm or exclude your diagnosis after that. Immunocompromised diseases, because they are lowering the immunity of the body, so the opportunistic infections may happen, including the corneal ulceration. Also, diabetes. The diabetes mellitus, if uncontrolled, it will also lead to depression of the immunity and increasing the incidence of opportunistic infections. Ocular surface diseases like severe dry eye, like corneal irregularities, corneal scarring, pinguculate regime, all of these may lead to irregular wetting of the surface with dryness and exposure, with frequent friction, and all of these factors will lead to corneal ulceration as well. Adnexal disorders like lacrimal system disorders, especially the dacryocystitis with chronic infection, also will lead to ulcer due to exposure of the cornea to the microbiological effects. Lid problems like entropion trichiasis. Entropion trichiasis leads leads to frequent friction and frequent trauma and the chronic trauma to the cornea, leading to ulceration. Firstly, leading to scratch and then development of corneal ulceration if not treated rapidly and properly. And finally, the hygiene, which is a very important factor to keep the eye sound and protected from the infections. The common causative agents for the infectious keratitis. I said before that these are four types of infective keratitis: bacterial, fungal, viral, and protozoal. Start with the protozoal because it's just one type, which is the acanthamoeba keratitis. Viral, the herpes simplex virus and the herpes simplex and the herpes zoster, but the commonest is the herpes simplex virus. It's rarely to happen with the herpes zoster, especially if it's of type herpes zoster ophthalmicus, which is including part of the ophthalmic sensory nerves, carrying the sensation from the corneal surface. In such case, uh, this patient will have a zoster ulceration, and you know the other associating signs and symptoms of the herpes zoster. But the commonest viral keratitis is the herpes simplex type 1. Type 2, is, as you know, it's common. It's one of the commensals which may be present in the birth canal in the vagina. So it may happen by the hand-eye touch or contamination, or may happen um, during birth for the baby as one of the causes of the neonatal ophthalmia. In the fungal keratitis, we have two types, filamentous and yeast. And filamentous is more common than the yeast. The yeast is more common in the immunocompromised patients because it's one of the opportunistic infection. The filamentous is either Fusarium, Alternaria, Penicillium, and Aspergillus. The commonest types of them are filaments and Aspergillus, while the yeast is either Candidiasis or Cryptococcus. Candidiasis is more. Finally, the bacterial, um, more than which is more variable than the fungal variant protozoal, is either Staphylococcus, which is in-site infection, Pseudomonas pyocenia. And here Pseudomonas and Streptococcus pneumoniae both can penetrate the intact epithelium, while the other factors, the other causes, needs opening to lodge in the corneal stroma and causing bacterial keratitis. E. coli, Neisseria meningitidis, or Neisseria gonorrhea, and you'll find that there is an associating uh, infection in the urinary tract. And finally, the atypical forms like Corynebacterium diphtheria. Here the pathophysiology of the corneal ulcer, but I will show here the pathophysiological process of the bacterial keratitis. Stages of progressive infiltration. Firstly, lymphocyte infiltrates in epithelium, which leads to necrosis. Second stage, a stage of active ulceration, tissue loss, and grayish infiltration with circumcorneal hyperemia, hypopyon, and desmatocele. Hypopyon is accumulation of the pus cells and other inflammatory cells in the antechamber, which may be combined with the organism itself. So it's called infective hypopyon or non-strial hypopyon. Stage of progression is number 3. Phagocytosis. Ulcers begin to heal if the phagocytosis is stopped and the natural process of the body could control the infection or with the aid of the treatment. So the ulcer starts to heal. But if the phagocytosis not stopped, it will go deeply, leading to perforation. Stage of cicatrization, epithelium covers the ulcers, and finally the ulcer heals with scars and opacity formation. This is a picture for hypopyon ulcer or bacterial ulcer, severe form, which is present in the peripheral part of the cornea, including here the limbus, and severe vascularization, as you see here, is the circumcorneal hyperemia and injection. Another photo for the fungal keratitis. As you see, it's less angry, it's with less infiltration, with less dissemination, but the problem here is a silent killer because it's going deeply in the cornea, leading to sudden corneal perforation. Severe inflammatory response, stromal necrosis, filamentous fungi can penetrate the intact decimus membrane. Finally, with the corneal perforation, as I told you. Symptoms. The common presentation is pain, photophobia, blurred vision, discharge, foreign body sensation, watering, and redness. But here you have to know a difference between the bacterial, fungal, and the viral keratitis. Bacterial and the viral may, in bacterial and the fungal keratitis, you may find colored discharge, but in the viral keratitis, just watering without colored discharge. The same with the acanthamoeba keratitis before necrosis. Signs In this table will show you the signs of each one, but I will focus on some points. Hypopyon is present in the bacterial and the fungal keratitis, not in viral and the protozoal. The corneal perforation will happen with both bacterial and the fungal, but you'll find that there is discharge in both with uh, dense opacity and dense necrosis in both bacterial and fungal. In the viral keratitis, it starts with the punctate epithelial keratitis, punctate epithelial erosions in the keratitis, and the pathognomonic and the characteristic sign is the dendritic ulcer, and I will show you now in the coming photos, which may be disseminated to be a geographical ulcer if misdiagnosed and or mistreated. And it's stained with the fluorescein and rose bengal stains. In protozoal, one of the signs. Pain is very severe. In the viral keratitis, there is diminished corneal sensation, just diminished, not absent, because it's absent in the neurotrophic and neuroparalytic ulcer. But in protozoal, the pain is very severe than you can expect, because you will find that there is a minimal inflammation on the surface of the cornea, but the pain is very severe, which is not matching with this pathology. This picture for hypopyon, above hypopyon in uh, the bacterial or fungal ulceration, and down there is acanthamoeba keratitis. Look here, you will find that the pathology and changes in the cornea is minimal, while the pain will be severe because of inclusion of the neurites of the sensory nerves of the cornea. Firstly, second part that it's always starts at the periphery with inclusion of the limbal parts or even sclera. So keratitis, limbites, and sclerites. So the pain is very severe in the acanthamoeba keratitis. Here the presentation of the viral keratitis. Down is the picture for the punctate epithelial keratitis, which is one of the uh, the common presentation pictures of the viral keratitis. Above is the characteristic dendritic ulcer. Other lesions similar to ulcers to differentiate. Above the corneal edema, there is edema with no injection, without angry eye, no infection, no discharge, no hypopyon. So you have to differentiate the corneal edema from the corneal ulceration. Down is endophthalmitis. It's corneal melting, but secondary to endophthalmitis. Infection from inside, not outside. Here, geographical ulcer and satellite lesions. Grading. According to this table, you will find all data, including the mild, moderate, and severe forms of the corneal ulceration, according to the size, depth of ulcer, stromal infiltrate, and scleral involvement. And you can grade its activity by the antechamber cells, grade 0, grade 1, 2, and 3. The same, you can review these tables. And finally, the treatment of the corneal ulcer. Bacterial, you will start with the topical antibiotics like ciprofloxacin, vancomycin, fluoxetine, moxifloxacin. But we can start with it. But if there is no improvement, we will shift to stop treatment and do scrubbing of the cornea and send it to the lab for culture and sensitivity test to be guarded and to be guided, to be guided by the culture regarding the antibiotic choice. Also, we can add oral antibiotics like the broad-spectrum antibiotics, ciprofloxacin. We can add mediatics like atropine or cyclopentolate to relieve the cyclitic pain or the uveal pain I mean, and to relax the spasm. Topical steroids may be considered at late stage after covering the antimicrobial agents, antimicrobial umbrella in our treatment, and lately we may add some weak steroid to decrease the scarring and inflammation. The same in fungal, you can remove the epithelium, you can debulk the infection, and you can help penetration of the antifungal agents. You will start with the topical antifungal. Inflammants, give natamycin, iconazole, amphotericin B, and miconazole. Also in candidiasis, you can add natamycin, fluconazole, clotrimazole, and iconazole. So inflammants, natamycin, and iconazole are shared between filaments and candida. With subconjunctival fluconazole, it may help, yeah, also systemic antifungals. And finally, if there is no improvement and you will find that it's progressing, please consider the excisional penetrating keratoplasty, which is called therapeutic or tectonic keratoplasty. Viral antiviral agents, acyclovir, ganciclovir, and trifluorothymidine. I'm giving actually both oral and topical cyclovir and ganciclovir with debridement of dendritic ulcer. Finally, the protozoal anti-amoebic like probamidine, which is not easily available in the Egyptian market, but we can add polyhexamethylene, biguanide, ciprofloxacin, clotrimazole, and miconazole may share in that. Debridement and oral ketoconazole. What about the non-infective corneal ulcer? I know that this topic is full of details, but I will run over all of them very fast just to enumerate and at the level of the postgraduate you have to know just the names and how to differentiate and a little information about the treatment. Non-infective ulcer, the difference between infectious and the non-infectious, that is a pain. Pain is severe in the infectious and a little bit, or there is no pain or a very minimal pain in the non-infectious, especially at the start. This charge is present in infectious, it's not in the non-infectious. Anti-chamber action is present in infectious but absent in the non-infectious, except in the case of associating uveitis. In infectious, it's almost central, or it's always central, but in the non-infectious, it's commonly peripheral. Trauma is infectious, but trauma not associating or not common in the non-infectious. Important types to know is marginal keratitis, Morin's ulcer, Syrian marginal degeneration, or another types associating the systemic autoimmune diseases, Dillon and lectinulosis. This is a marginal keratitis caused by the hypersensitivity to staph, oxytocin, and cell wall proteins with deposition of anti-antibody complex in the peripheral cornea. So it's local toxicity to these factors. So it's not infective ulcer in nature, but it's just reaction to another infection. These are the signs which may be which may be presented firstly by the chronic blepharitis, chronic mucobariant conjunctivitis, and so on. Look here, it's in the peripheral part of the cornea, superiorly or inferiorly. Yes. Treatment of the original cause, which is the blepharitis or mucobariant conjunctivitis, and you can add after that weak topical steroid, maybe combined with topical antibiotic, tetracycline orally, yeah, for children, breastfeeding and pregnancy erythromycin. Treatment of blepharitis. Finally, as I told you, here the second one, which is the Morin's ulcer. It's one of the aggressive autoimmune ulcers with erosion and thinning of the peripheral part of the cornea, as you see here. Yeah, but Alhamdulillah, it's rare. I just saw it once or twice during my life. Aggressive form with necrosis of the cornea, sclera. So it's like eroding the eye. It's very devastating with very difficult situation, which is um, which is intractable for treatments. Complications: severe astigmatism due to extensive vascularization and fibrosis, perforation following minor trauma, secondary bacterial infection may happen after. Treatment: steroid, cyclosporin, artificial tears, collagenase inhibitors like acetylcysteine. And finally, lamellar keratoplasty. It's recommended in the early or in the moderate cases. Don't wait for the severe cases for the severe changes to happen. Tertiary marginal degeneration and how to differentiate it from the Morin's ulcer. Idiopathic thinning of peripheral cornea, young adults to elderly patients, 75% males, usually bilateral, usually asymptomatic, gradual painless drop of vision due to astigmatism. A few patients experience episodic pain and inflammation, slowly progressive non-inflammatory or asymmetrically bilateral peripheral corneal thinning with vascularization. And finally, opacity and lipid deposition, as you see in the pictures on the right side. This is the tertiary marginal degeneration, which should be differentiated from the arca senilis, the peripheral corneal degeneration, and Morin's ulcer. Perforation is rare because it's less progressive. It's not like Morin's, but it may be spontaneous or following the minor trauma. The cornea will be very weak and vulnerable. Pseudotracheia sometimes develop. And pseudotracheia means it's not real tracheum because it's just adhesion between the conch and part of the cornea with a bridge just beneath the like a bridge. There is a space between this attached part of the conch. Management is safety spectacles, contact lenses, surgery, crescentic excision of the gutter with lamellar or full thickness, corneoscleral patch grafts, transplantation to compensate for the thin part. Finally, the PUK, peripheral ulcerative keratitis, which is associated with the systemic autoimmune disease. The most common one is the rheumatoid arthritis. So, rheumatoid arthritis may be associated with the PUK. Yani it's enough to know that. PUK, rheumatoid arthritis. It's crescentic ulceration, contact lens cornea, with this thinning all around, giving the cornea this picture like the contact lens. Finally, progressive thinning with perforation, limbites, sclerites, or keratitis. Peripheral corneal involvement in the rheumatoid arthritis. Maybe silent, without inflammation or with inflammation. The treatment principally is systemic for the systemic autoimmune disease with the immunosuppression with rheumatologist. Topical tears, antibiotic, and it's recommended to be artificial tears without preservatives. Antibiotics prophylaxis. Steroids may worsen thinning, so are generally avoided. Steroids, but you can use another forms like you can use systemic steroid, but the topical steroids is not recommended. You can put instead of them the cyclosporin A. The systemic steroids and tetracyclines are also considered. Delin means depression with no infection. Tissue loss in the cornea, especially the peripheral part, it's autoimmune reaction in this part. So lubricate it with the lubricants, a minimal dose of antibiotics to guard against secondary infection, and weak steroid. This is for self-test. What about this? Do you see? Can you differentiate between both images? Down is the hypopyon, but the eye is quiet. So, do you think that there is infection here? Above, what about this corneal staining? Is it infection? The eye is quiet. So I brought these pictures to just brainstorming and to apply what I said in the previous slides. So hypopyon here in the inferior picture is strial hypopyon, inflammatory cells with no infection, which may happen with autoimmune diseases like Behçet disease. So there is reaction due to uveitis, but there is no infection. So it's called strial hypopyon, and it's with some characteristics. Above here, there is a corneal staining, but the eye is quiet. So this is just scratch. This is just scratch, no infection. So please differentiate between, you have to find and correlate the clinical finding together to know about the ulcer, scratch, strial hypopyon, and the infectious and non-infectious presentations or causes of the keratitis. Approach to diagnosis: history. As I told you, trauma, contact lens wearing, trauma with vegetables will lead your mind to think. Systemic workup to know about the systemic and autoimmune diseases. Communication with other specialists, like rheumatologists in case of autoimmune disease, or in diabetes with the internist and other associating factors. And finally, the treatment, as I told you before, and thank you so much.